Welcome back, focused learners, to another explainer. Today, we're tackling a situation that literally demands immediate clarity in the middle of total chaos, and that's the clinical approach to dyspnea, or breathlessness. Look, when you're faced with a respiratory emergency, the stakes are incredibly high, right? The clock is ticking. You absolutely need a fast, intense, and highly structured framework to cut through the panic and nail the diagnosis. And well, that's exactly what we're going to build today.
I mean, just imagine this scenario for a second. A patient gets rushed in, gasping for air. Monitors are screaming, the room is super tense, and there is just this primal urgency in their struggle to breathe. It feels completely chaotic. Adrenaline is spiking. But in the middle of all that clinical chaos, how do you step back and find the calm, diagnostic truth? You have to purposefully slow down your mind. You need to adopt a reassuring, methodical cadence and really rely on a structured approach instead of just, reacting to the noise.
Okay, let's dive into this with Section 1, Defining the Subjective Sensation.
Before we can even begin to diagnose the problem, we need to completely understand what the patient is actually experiencing. Officially, dyspnea is defined as an unpleasant subjective awareness of the sensation of breathing. Now, the absolute key word there is subjective. Breathlessness is the patient's absolute truth. It is not just a low oxygen saturation number blinking on a monitor. Seriously, a patient could have a totally normal SpO2 and still feel like they're suffocating. Or actually, scratch that, vice versa. We have to treat that internal, really unpleasant awareness that they are working hard to breathe as our #1 clinical clue.
Moving on to Layer 1, the timeline of onset.
To make sense of this symptom, we're going to use what I like to call the algorithmic funnel, starting super wide and narrowing down our suspects. Our very first major diagnostic tool right at the top of this funnel? Time. The timeline categorizes the crisis. It acts as the ultimate clinical clock. We basically drop the onset into 4 distinct chronological buckets. First up, we've got abrupt onset, happening in mere seconds to minutes. Second is acute, which develops over 1 to 2 hours. Third is subacute, building over days to a few weeks. And finally, chronic, which, has been hanging around for months to years. Just by pinning down exactly how fast the symptom appeared, you've already thrown out like 3/4 of the medical encyclopedia. Let's look at the fastest timelines first, the hyperacute emergencies. If the onset is abrupt, like seconds to a few minutes, you've got to think of immediate life threats. Think of a massive pulmonary embolism completely blocking blood flow, anaphylaxis slamming the airway shut, or the catastrophic sudden loss of air escaping into the chest cavity in a severe tension pneumothorax. Now, if it takes 1 to 2 hours, our acute bucket, we're looking at rapidly inflammatory or reactive states, things like bronchial asthma, a really fast advancing pneumonia, or edema of the larynx.
Now let's contrast those immediate life threats with the slower building conditions. A subacute onset, days to weeks, points toward things that take a little time to either accumulate or break down. We're talking about a progressively accumulating pleural effusion, the slow neuromuscular paralysis you see in Guillain-Barré syndrome, or the metabolic disruption of DKA. And if it's chronic, meaning months to years, well then you're dealing with structural, long-term degradation like COPD, pulmonary tuberculosis, or chronic left ventricular dysfunction. So you see how the timeline instantly sets your priorities. It's literally a game changer.
Right, on to Layer 2, positional triggers in dyspnea.
Now we look at how simple things, literally just gravity and sleep, profoundly affect the fluid and air dynamics in the lungs. And this brilliantly illustrates the vital diagnostic difference between two conditions that sound kind of similar but operate on totally different physiological clocks. On the left, we've got orthopnea. This is breathlessness that develops immediately after lying down flat. Gravity is shifting that fluid into the lungs instantly. On the right is paroxysmal nocturnal dyspnea, or PND. Here, the patient goes to sleep totally fine, but wakes up gasping 2 to 4 hours after the onset of sleep. This timing difference, it is a massive clue about exactly how the left ventricle of the heart is handling fluid overload at night.
Let's keep moving down to Layer 3, the diagnostic algorithm.
So we are now entering the narrowest part of our funnel to finally separate the respiratory from the cardiac causes. Let's apply this algorithmic approach really carefully. If your patient has orthopnea combined with bilateral basal crepitations, that distinct crackling sound right at the base of the lungs, your primary suspect is absolutely left ventricular failure. The left side of the heart is just failing to pump fluid out. Now, if you see physical edema in the legs and a raised jugular venous pulse in the neck, well, that clinical sign immediately points your compass straight toward the heart, specifically congestive cardiac failure, because the backup of fluid is now systemic.
Now, what's really interesting about this slide is how starkly different the lung exam can be depending on the underlying pathology. A recurrent attack with wheezing and rhonchi, that points straight to the narrowed airways of bronchial asthma. But listen to this description. A sudden onset tracheal shift combined with a silent, resonant hemothorax. The chest is hollow, it's hyper-resonant like a drum, and it is eerily quiet because the lung has entirely collapsed. That right there is the absolute hallmark of a pneumothorax. Meanwhile, if you've got a fever, a cough, and harsh bronchial breath sounds, that suggests the lung tissue is consolidated with infection, which is classic for pneumonia.
But hey, what if you listen to the lungs and the chest is totally clear? You must immediately widen your gaze. A clear chest with dyspnea on exertion should literally make you look at the blood, specifically severe anemia. The lungs are working just fine, but there's just no hemoglobin to actually carry the oxygen. Furthermore, if you have a patient with a perfectly clear chest, severe breathlessness, and recent significant stress or anxiety, you've got to consider concealed systemic issues. Things like a hidden malignancy or even psychogenic issues like a conversion disorder.
Almost done. Section 4. Clinical synthesis and conclusion.
So we've cascaded down through the timeline, through positional triggers and specific physical signs, bringing it all together. So the crucial point is that these final associated symptoms are the keys to unlocking the exact diagnosis. You just pair the dyspnea with these clues. Pleuritic chest pain, so pain when taking a breath, suggests pneumonia, a PE, or maybe a rib fracture. Central non-pleuritic crushing pain, that points to a myocardial infarction or a massive PE. Stridor indicates a terrifying emergency upper airway obstruction. And lip pursing with a chronic cough is a classic visible compensation mechanism for COPD. These aren't just random symptoms, guys. They're like giant puzzle pieces.
Dyspnea is absolutely terrifying for the patient. But for you, the clinician equipped with this framework, it doesn't have to be. By systematically moving through the onset timeline, recognizing those positional triggers, and hunting for precise physical signs, you completely remove the guesswork. So the next time a patient looks at you with wide eyes and says, "I can't breathe," will you let the panic take over? Or will you calmly listen to their timeline and clinical science to find the truth? Keep learning, stay methodical, and we'll see you in the next explainer.